Hello everyone. Today we'll be talking about middle ear and its diseases. Okay, and initially we'll be talking about anatomy of the ear, and we will divide the ear into different parts, and then we'll be talking about physiology, and mainly we'll be focusing on the middle ear and its diseases. Okay, now let us discuss about the ear parts that are related to bone. They are squamous, petromastoid, styloid, tympanic, and zygomatic process. Okay, these are the ear that are related to this bone structure. If we cannot remember these things, then it will be difficult for all of us. Now let us talk about ear. Ear is divided into three parts. They are external ear, middle ear, and the inner ear. An external ear that extends from the auricle to external auditory canal. In some books say we can include tympanic membrane in external ear, but dhingra says different things. So we can compose this external ear is composed of auricle and the external auditory canals, and middle ear composed of tympanic membrane and ear ossicles, and then lastly there is presence of oval window. Okay, so it extends from tympanic membrane to oval window, and inner ear that is inside the oval window, that is called as inner ear. Now how the development of ear take place? Initially we have cranial neuropore and the oral neuropore. Okay, you can in the figure also you can see over here there is presence of cranial and oral neuropore. This is cranial and this is oral neuropore, and this gives different arches. Among them, for ear, the most important thing is first and second pharyngeal arches. Okay, and now let us talk about external ear. So external ear that is derived from first and second pharyngeal arches. That external ear composed of pinna and EAC. Okay, and pinna that mainly derived from sixth hillocks. Okay, and EAC that is formed by first arches. Now how the middle ear forms? Middle ear is formed by tympanic membrane is formed by all three zone layer. Middle ear cavity and steroid tip that is derived from first pouches. Okay, and ossicles, malleus, incus, and stapes. Among them, malleus and incus that is derived from first arches, and stapes that is derived from second arches. Now, how inner ear forms? So around the otic vesicles, we have the mesoderm from the brachial arches. Okay, and mesoderm condenses and form otic capsules. So otic capsule from bony labyrinth, membranous labyrinth is formed by otic vesicles. So this thing is slightly difficult. Now let us discuss about these things. So already discussed about first and second pharyngeal arches. Between first and second pharyngeal arches there is presence of otic placode. Okay, and this otic placode imaginate and it forms otic peds. This otic peds consists of lining surface ectoderm. This surface ectoderm moves away from it and it forms otic vesicles. Okay, and these otic vesicles form membranous labyrinth. Okay, membranous labyrinth. So otic vesicle from the membranous labyrinth. Around the otic vesicle there is presence of mesoderm. This mesoderm condenses and form otic capsules. This otic capsules gives bony labyrinth. Okay, so this is the things we have to know about in inner ear. Okay, and one of the most important things over here is inchondral ossification over here. This is one of the most important things. If the ossification is disturbed over here, this might be there like otosclerosis. Okay, now let us talk about middle ear. In middle ear, we'll be discussing about the middle ear together with estrogen tube, auditus, antrum, and the master ear cell is called as middle ear cleft. Now you can see in the figure this is antrum over here. Okay, this is antrum over here, this is auditus over here, attic over here, middle ear over, master ear cells over here, estrogen tube over here, and this is nasopharynx. Okay, and this antrum is connecting. This is connecting between. Okay, this is antrum is over here, and this auditus is communicating between antrum and the attic. Okay, so and this is middle ear over here, and this is estrogen tube. Okay, so we have to remember this thing as well. Now let us move forward. On the basis of this tympanic membrane we have lateral boundary. Okay, lateral boundary extends. Okay, lateral boundary, and middle ear has lateral boundary as well, and that lateral boundary can be divided into three parts on the basis of tympanic membrane. So if it is present above the tympanic membrane, that is called as epitympanum. In front of tympanic membrane, that is called as mesotympanum, and below tympanic membrane, that is called as hypotympanum. Okay, the portion of the middle ear around the tympanic orifice of the estrogen tube, so is sometimes called as protympanum. Okay, so now let us discuss one of the most important topic over here. Okay, now you can see over here this is box model of the middle ear. To see the boundary we have to remember these things. Okay, this is roof, this is middle, and this is floor and interior posterior. Okay, this we have to now open the box. Okay, so opening the box, you can see over here I am going to opening the box. Okay, now I am opening the box. Okay, so now we can divide the same things. Okay, and there is floor and there is roof over here. Okay, So I am opening the same box model over here. Okay, now we'll be seeing furthermore in this video as well. Okay, so same things. Now let us we are opening. Okay, now you can see over here, this is anterior. Okay, this is anterior, this is medial, this is floor and lateral. Okay, and this is roof and this is floor. Okay, now this is the most important things over here, and what the structure over here is. Okay, and this is posterior part over here. Okay, and medial, anterior, posterior, lateral. Remember, okay, this is tibio-tympanum, stretching tube. Okay, and then you can see what structure you can remember. There is presence of jugular valve. Okay, this is internal carotid artery, and this is carotico-jugular crest. Okay, this is most important things we'll be talking furthermore. Now we can remember these things same here. Okay, now you can see anterior consists of canal for tensor tympani and opening of stretching tube, and medial wall consists of the medial ear cavity composed of opening of the medial wall consists of the oval window, round window, and 3, 4, 5, that is process of cochlear formation. Okay, you can see in the figure, and that is also consists of horizontal canals and facial nerve as well. Okay, and this posterior wall composed of pyramid. You can see over here, this is pyramid and auritus. Lastly, that is cora tympani over here. Okay, and you can see over here, this is carotid artery and this is jugular valve. Okay, so you can see over here, in this way you can you can understand the walls of medial ear over here. Okay, now let us talk about auritus and the antrum. Auritus is the opening through which attic communicates with the antrum. Okay, the bony prominence of the horizontal canal lies on the medial side, while the fossa incudis to attach, which is attached to the soft process of incus, lies laterally. Facial nerve courses thus below the auritus. Now here vesicles, malleus, incus, and the stapes. And malleus and the incus have the saddle joints over here. We can see what this is like. Okay, and you can see like a ball. Okay, so this is saddle joint over here. Okay, malleus, incus, like so. So there is presence of malleus and incus, that is saddle joint over here. Incus and stapes that consider that look like ball and the socket, so it is ball and socket type, and here you can see over here, this is saddle like. Okay, so malleus and incus has saddle joint, and this incus and stapes have the ball and socket joint. Now it's same thing. Okay, malleus, incus and stapes, it looks like horse stapes. Okay, so you have to remember that things. So you can see over here, foot plate, posterior cross, anterior cross, posterior cross, foot plate, and we have presence of incus, here is presence of process, articular with malleus. Okay, lenticular process, long process. Okay, lenticular process is one of the most important thing you have to remember. And here over here in malleus, you can see here neck. It is also presence of head only, there is no neck. Okay, so here is head and neck. Anterior process and lateral process. Here is presence of long process, short process, lenticular process. There is presence of anterior and lateral process. There is presence of manubrium. Okay, with these things, now let us move towards the stretching tube. Stretching tube also called as pharyngotympanic tube. It's bony and cartilaginous part. Okay, 46 mm. Lateral 1/3 is bony and middle 2/3 is cartilaginous. Okay, it's the most narrowest part. You can see in the same figure as well. Not supply to middle ear, tympanic plexus, tympani knob, and supply to tensor tympani from the 5th cranial lobe, supply to stapes, that is from 7th cranial lobe. Okay, now blood supply. So it is derived from both external and internal carotid artery, anterior tympanic artery, sternomastoid artery, superficial petrosal artery, inferior tympanic artery. So these are the blood supply of the middle ear. Venous drainage, you can see over here, one of the most important topic, one of the most interesting over here. This is dhingra. This is superior sagittal sinus and this is inferior sagittal sinus. Okay, between the dhingra. Okay, you can see over here, this is superior sagittal sinus and this is inferior sagittal sinus, and there is presence of smell that is called as lateral transverse sinus. Okay, so these three things. Now these three veins are connected by great vein of Galen. Okay, and you can see over here a branches is coming from great. This is great vein of Galen. This is joining over here. Okay, you can see over here, this is venous drainage. Okay, and we will be discussing this topic separately. Okay, now physiology of middle ear. Stretching tube helps in drainage of fluid and maintain atmospheric pressure. Middle ear mechanics, total surface area of the tympanic membrane, that is 90. Effective vibratory area of tympanic membrane, that is 55. Surface area of stapes fulfilled, that is 3.2 mm square. Aerial ratio, that is 17:1. Lever ratio, that is 1.3:1. Okay, now this is the things we have to remember over here. Now we'll be entering into main topic today over here, and disease of middle ear. Okay, before this, now let us say about eustachian tube, function of the eustachian tube. Okay, now eustachian tubes normally drains secretion, okay, and it maintains the atmospheric pressure. Okay, so when there is repeated infection over nasopharynx, what happens when there is repeated infection? When there is repeated upper respiratory tract infection or something else. So eustachian tube consists of most narrow part, that is called as isthmus. That isthmus can block this. When the isthmus causes blockade, what happens? The secretion cannot be drained. Secretion will be collected in the middle ear cavity. Okay, when the middle ear cavity contains this secretion, it will be collected for more days. To extend, what happens? The bacteria grows over here, and that bacteria will cause us what? That bacteria will cause us to secrete that things, and it is converted into pus. Okay, neutrophil come over there, neutrophil fight, neutrophil died, and that forms pus. Okay, so now the pain begins. Okay, now the pain begins. Now the fluid must to be drained out. Okay, must to be drained out. So it is trying to drain out from the middle ear cavity. So it will sometimes it will press the tympanic membrane, or it tries to try to drain from anywhere. Okay, from its course. And so what happens at night time? What happens? It try to come out, try to drain out. Then what happens? It perforates. Then what happens? The discharge come out. At that condition, there will be no pain. There will be relief. Okay. So this is the things over here. This is the mechanism over here. Okay. So same things. Otitis media, suppurative, non-suppurative, and suppurative, that consists of acute and chronic otitis media. This is pathophysiology, same thing. Non-suppurative otitis media with effusion, adhesive otitis media. On a specific COM, chronic otitis media. Mucosal type, squamous type, and specific composed of tuberculosis and allergic type. Okay. Now same thing. Acute tubal blockage, absorption of middle ear gases, negative pressure in middle ear, retraction of tympanic membrane, transitute in middle ear, hemorrhage, prolonged tubal blockage, dysfunction, otitis media, effusion, then watery or mucous discharge, atelectatic ear or perforation, retraction pocket, cholestoma, erosion of inculostaphyal joint. Okay, so this is the main important things over here. This is the mechanism. Okay, and now everything going over here. How can we define acute otitis media? Acute otitis media is defined as infection of the middle ear spaces. Infection of the middle ear can be viral, bacterial, or co-infection. The most common bacterial organism causing otitis media are Streptococcus pneumoniae, non-type A as influenza, and Moraxella catarrhalis. Etiology: otitis media is multifactorial disease. Infectious, allergic, and environmental factors contribute to and include decreased immunity due to immunodeficiency, immunodeficiency virus, diabetes, and other immunodeficiencies, genetic predisposition, mucin, which includes abnormalities of this expression, especially of regulation of MUC 5B. Okay, anatomic abnormalities, ciliary dysfunction, cochlear implants, vitamin A deficiency. Okay, so these are the etiology of acute otitis media. So pathophysiology, same things. Upper respiratory tract infection over here. What happens? Due to constriction of the anatomical space of the middle ear, the edema caused by inflammatory process obstruct narrowest part of the eustachian tube, leading to decrease in the ventilation. This lead to cascade events resulting in a decrease in negative pressure in the middle ear. Increases exudate from the inflamed mucosa and build up mucosal secretion, which allows for the colonization of the bacterial and viral organism in the middle ear. The growth of these microbes in the middle ear then leads to suppuration, eventually frank purulence in the middle ear space. This is demonstrated clinically by bulging or erythematous tympanic membrane and purulent middle ear fluid. This must be differentiated from chronic otitis media, which present thick amber colored fluid in the middle ear space and retracted tympanic membrane endoscopic examination. Okay, both will yield tympanic membrane motility on tympanometry or pneumatic otoscopy. These symptoms include pulling or tugging at the ears, irritability, headache, disturbed or restless sleep, poor feeding, anorexia, vomiting or diarrhea. Approximately 2/3 of the patient present with fever, which is typically low grade. Okay, this is the things. Now on the otoscopic examination, will be the first and most convenient of way of examining the ear will yield the diagnosis to experience eye. In acute otitis media, the tympanic membrane may be dilated or normal. There may be fluid in the middle ear space. In suppurative otitis media, there will be obvious purulent fluid visible and bulging tympanic membrane. The external ear canal may be somewhat edematous, so significant edema which allowed the clinician to suspect otitis externa, which may be treated differently. In the presence of external auditory canal edema, it is paramount to visualize the tympanic membrane to ensure it is intact. If there is intact tympanic membrane or painful edematous EAC, topical drops will be added to treat AOE. If there is perforation of the tympanic membrane, then EAC edema can be assumed to be reactive and topical medication such as will be used, but an agent approved for using the middle ear such as ofloxacin must be used as the other agent can be ototoxic. Okay, and tympanosynthesis may be used to determine the presence of middle ear fluid followed by culture to identify pathogens and it can improve diagnostic accuracy and guide treatment decision, but it is reserved for extreme or effective case. So now we have diagnosed the things. Okay, so we have pain, swelling. If there is perforation over there, the pain will be subside. Okay, so there will be pain, fever. Obviously there will be fever. Okay, and there will be discharge. Okay, and discharge must be was, and we have to look for we have to look by the tympanosynthesis if the fluid is there, and we have to do otoscopic examination. Okay, from these things now we can diagnose this is acute otitis media. Now we can diagnose these things and how we can treat the case. Okay, so if there is clinical evidence of operative acute otitis media, how we can give oral antibiotic are indicated to the bacterial infection. High dose amoxicillin or second generation cephalosporin are first line agent. If there is tympanic membrane perforation, okay, treatment should proceed with ototopical antibiotics safe for middle ear use such as ofloxacin rather than systemic antibiotic, and this deliver much higher concentration of the antibiotic without any systemic side effect. For those patients whose symptoms do not improve after treatment with high dose amoxicillin, high dose amoxiclavulinate will be used. Okay, children who are vomiting or the situation in which oral antibiotic cannot be administered, ceftriaxone can be administered either intravenously or intramuscularly. Okay, systemic steroid and antihistaminic have not shown to any significant benefits. Patients who experience 4 or more episodes of acute otitis media in the past 12 months should be considered candidates for myringotomy. Okay, with tube chromate placement according to American Academy of Pediatric guideline. Now let us define these things. Acute otitis media, ear infection usually accompanied by symptom of fever and pain in the ear. Audiogram, a test to measure hearing with ring threshold measured in decibels. Chronic otitis media with effusion. Otitis media with effusion present for at least 3 months. Chronic suppurative otitis media. Chronic otitis media with a perforated tympanic membrane, intermittent or continuous otorrhea. Duration of otorrhea to define disease is debated. Some suggest 2 weeks, others 6 weeks, and 3 months. Grommet, small hollow to be inserted into tympanic membrane to create symptomatic COME and result effusion. Myrinoplasty, an operation to repair the tympanic membrane. Myringotomy, an operation to make an incision in the tympanic membrane. Otitis media, inflammation of the middle ear. Otitis media with effusion, serous or mucous effusion in the middle ear without sign or symptom of infection. Usually the effusion is tenacious, hence OME is colloquially called glue ear. Otorrhea discharge from the ear. Otoscope, an instrument to examine the ear. Recurrent acute otitis media, usually defined as more than 3 episodes of acute otitis media in 6 months or more than 4 episodes in a year. Okay, now you can see one of the case I have taken from the journal. A 5-year-old boy is taken to doctor by his parents because both they and his school teacher have noticed that for several months his hearing seems poor. He is also beyond his peer group in the spoken and written language. They are concerned about poor behavior. There is no preceding history of ear infection and boy is otherwise well. The boy's father also had hearing problems in childhood. Examination with an otoscope reveals of effusion behind tympanic membrane, giving a diagnosis otitis media with effusion. Okay, this is confirmed by tympanometry. An audiogram reveals a 20 decibel hearing loss. After a discussion of the option, the parent decided to proceed with bilateral grommet insertion under general anesthesia, which normalized hearing leads to improvement in language and behavior. After a year, the grommets fall out, but the left membrane has a residual perforation. Subsequently, the child suffered recurrent left-sided mucopurulent otorrhea, which occurs every few months. The child is repeatedly treated with topical antibiotic drop, but is unable to continue with his swimming lesson. At the age of 8 years, he undergoes a left myrinoplasty which successfully repairs tympanic membrane. The child has no other problem. Okay, so this is the case, and now we have management. Manage the place. We are doing this over here. Okay, And now perforation, past tense, past flaccid. So now let's talk about tympanic membrane. Tympanic membrane consists of pars tensa and the pars flaccida. Okay, so pars tensa is the central part. Okay, and this central part also consists of peripheral part. Normally pars flaccida is the superior part or peripheral part. Okay, so peripheral superior part we can say pars flaccida. So if there is perforation in the pars tensa in centrally, that is called as tubotympanic. If the peripherally or pars flaccida take place, perforation take place in that part, then that is called as eticoenteral type. Okay. Now chronic otitis media, mucosal diseases, squamous diseases. Mucosal disease is divided in three parts: active, inactive, healed. Active is called as chronic suppurative otitis media. Inactive, permanent perforation. Healed, adhesive otitis media. Squamous disease, retraction pockets and acute cholestoma with discharge. Okay. Now you can see over here types of perforation in tympanic membranes means chronic suppurative otitis media. Central perforation over here. Okay. And central perforation, anterior, medium size, subtotal perforation, or perforation of destruction even the fibrous annulus, attic perforation, posterior superior marginal perforation. Okay, and there is over here. Okay, and now types of CSOM. Okay, and CSOM divided into tubotympanic and eticoenteral. Okay, and now let us talk about mucosal type. Mucosal type is a chronic disease of the middle ear cleft with persistent perforation in the pars tensa. More common in lower socioeconomic population, aerobes, mixed organism or mixed infection. Staphylococcus aureus, Pseudomonas aeruginosa, Streptococcus klebsiella. Okay. Now in chronic otitis media, mucosal type, the most common things over here are ear discharge, offensive, mucor or mucopurulent, constant or intermittent. Okay, discharge appear mostly at the time of upper respiratory tract infection or accidental entry of water into ear. Examination under microscope is essential in every case to provide useful information regarding presence of granulation in growth of squamous epithelium from the age of perforation, status of ossicular chain, tympanic sclerosis and adhesion, and ear which appear dry may show hidden discharge under microscope. Rarely, cholestoma may coexist with the perforation and can be seen with a microscope. Okay, so what is the cause of mucosal type? The cause of the mucosal type are eustachian tube, perforation tympanic membrane and broadbone. Eustachian tube blockage is due to nasopharynx, nose or pharynx infection. Okay, and from repeated blowing as well. And occasionally, regurgitated milk or vomitus in infant can reach the middle ear cavity through the eustachian tube. Perforation in tympanic membrane may reach the middle ear cavity through an existing perforation tympanic membrane when water enters the external auditory canal while bathing, putting ear oil or cleaning the ear with cotton buds or matchstick etc. Broadbone, influenza and exanthematous fever. Okay, now let us talk about active and inactive. Okay, so active means it is discharging and inactive means period of remission when the ear is dry. Symptom during active stage, there is ear discharge, hearing loss, varying degree brought on notice. If it is unilateral and of mild degree. Sign during active stage, ear discharge, that is discharge is one of the most important things. If the discharge is moderate to proficient amount, mucopurulent nature, and it is colorless and greenish yellow, or may not be fall small smelling, and it is not brown stain, then that is maximally confirmed of a chronic otitis media of mucosal type. If the discharge is color, bloody, fall smelling, okay, then we have to suspect it might be cholestoma. Perforation tympanic membrane, okay, and seen in the pars tensa, edematous or congested miliary mucosa, seen through a large perforation, ossicles, intact ossicular chains, the discontinuity of the ossicular chains may seen through a large perforation. There is polyp, conductive hearing loss. Inactive stress symptoms are hearing loss, okay, there is no discharge. The hearing loss might be varying degree but notice. There might be perforation tympanic membrane in the signs. How will you investigate the case? In case of these things, we can have to investigate by audiogram, X-rays of the mastoid, post cultural sensitivity. Okay, now in audiogram, we have to look for the intercoscular chain is here or not. So if the ear conduction level is less than 45 decibel, okay, that is there is intercoscular chain. But if the ear conduction level of more than 45 decibel suggest, then the ossicles are also involved, either discontinuity or fixation. Okay, X-ray of the mastoid. You have to look through lateral oblique view, bilateral and Townes view. which are not done routinely. X-rays will be done when the cholestoma is suspected, post-culture and sensitivity. And how will treat the case? Treatment is during active and inactive stage. Active stage, general measure and medical treatment, surgical treatment, general measures and medical treatment, and surgical treatment. General measure and medical treatment, we have to clean the ear, mopping on suction of the discharge, topical antibiotic ear drop for 7 to 10 days, oral antibiotic for about 7 days, treat upper respiratory tract infection, sinusitis, etc. when present. Okay, and surgical treatment, we have to do meningioplasty, cortical mastectomy with meningioplasty. Okay, some surgeons perform meningioplasty even when the ear is discharging. However, most surgeons prefer to do meningioplasty after making the ear dry. Okay, the next thing is cortical mastectomy with meningioplasty. Some surgeons prefer to do cortical mastectomy together with meningioplasty if general measure and medical treatment fails to make the ear dry. And we can do overall polypectomy. Okay. Now, treatment during inactive stage. Okay, chemical cautery. When the perforation is about 2 mm or less in diameter, fat graft, meningioplasty measure is failed. Okay. So when the perforation is more than 2 mm in diameter, meningioplasty is large, indicated when the perforation is larger than 2 mm diameter or if measure fails. Meningioplasty, that is defined as surgical closure repair of the tympanic membrane perforation. Okay, same thing, meningioplasty, that is called defined as surgical closure of the tympanic membrane. Prerequisite for meningioplasty are dry ear, age after 7 years of age, aims of meningioplasty to permanently stop ear discharge to improve hearing. Okay. These are the things. And procedure, underlay and overlay. In underlay, initially we have to do incision of the perimeatal, post incision we can give perimeatal, post auricular, in oral incision. Surgical excision the rim of perforation margin is done. Okay, and in left ear incision is made from 1 to 6 o'clock. In the right ear incision is made from 11 to 6 o'clock in the posterior bony EAC. Okay, now skin periustal flap is then raised in the posterior part EAC, and posterior tympanic annulus is also lifted from the bony tympanic sulcus along the tympan posterior part of tympanic membrane. This flap is known as tympanomeatal flap. In the overlay technique, the graft is placed under the tympanomeatal flap and the graft is placed medial to in contact with the remnant. Okay, and this is called as underlay technique. Overlay, you can see over here. Alternatively, in overlay technique, a circular skin incision is made uniformly, but completely around the bony EAC. The skin periustal flap is then off to annulus. However, unlike in the underlay technique, the annulus is not elevated, rather outer epithelial layer of tympanic membrane. The skin periustal flap, along with the fibrous layer of tympanic membrane, excised. The graft is placed on the fibrous layer of remnant tympanic membrane. Okay, now we have to define these three things: ossiculoplasty, surgical reconstruction of the ossicular chain; tympanoplasty, operation done to remove disease from middle ear cavity; reconstruct the middle ear hearing mechanism with or without tympanic membrane grafting, without master surgery. Okay, now lastly we have next thing, that is chronic otitis media. Okay, squamous type, eticoenteral type. Okay, chronic infection of the mucosa of the middle ear cleft. Okay, and this is called as chronic infection of the mucosa of the middle ear cleft. Squamous type of COM is divided into active and inactive. Pathologically, cholestoma and conversion tissue. Okay, cholestoma is defined as presence of keratinizing squamous epithelium in the middle ear cleft. Skin in the wrong place. It consists of a sac with a narrow neck, is lined by keratinizing squamous epithelial surrounded by granulation tissue. The inner surface of the sac continues to produce keratin. This discommitted dead keratin collects in the sac. Clinically, it is described as full smelling, outer yellowish colored cheesy material commonly in the region of pars flaccida or in the posterior superior quadrant of pars tensa. Pathologically are associated with the following pathological processes: cholestoma, otitis and granulation tissue, ossicular necrosis. Okay, and cholesterol granuloma. Symptom: ear discharge, usually scanty but full smelling due to bony destruction. Discharge may also scanty that the patient may not even be aware of it. Total cessation of discharge from an ear which has been active till recently should be viewed seriously, as perforation in these cases might be sealed by crusted discharge, inflammatory mucosa or a polyp. Obstructing the free flow of discharge caused in this case may find its way internally and cause complication. Hearing loss. Hearing is normal when ossicular chain is intact or when cholestoma, having destroyed the ossicles, bridges the gap caused by destroyed ossicles. Okay, and bleeding, it may occur from the granulation or from polyp. Sign: perforation, okay, in the attic or posterior superior marginal type. Retraction pocket, and invagination of tympanic membrane is seen in the attic or posterior superior area of pars tensa. Okay, stage of retraction pocket. Okay, there are tympanic membrane is retracted but does not contact with the incus. Tympanic membrane is retracted deep in contact with the incus. This is mild form of retraction. Stage first. Stage 2, middle ear mucosa is not affected. Stage 3, Medial atelectasis. Tympanic membrane comes to lie on the promontory ossicles. Medial ear space is totally or partially obliterated, but the middle ear mucosa is intact. Okay. Tympanic membrane can be lifted from the promontory suction tip. Okay. And stage 4 that is called as adhesive otitis media. Tympanic membrane is very thin and wraps the promontory ossicles. There is no middle ear space. Mucosa lining the middle ear is absent. Tympanic membrane gets adherent to promontory. Retraction pockets are formed and may collect keratin plaques and form cholestoma. It is a long process that incurs in staphyloid superstructure in common in such cases. Okay, so cholestoma is pearly white. Flakes of cholestoma can be sought from the retraction pocket. Examination under operating microscope form an important parts of clinical examination and assessment of any type of CSO. Investigation we can do under microscope, okay, and it may reveal presence of cholestoma. Okay, tuning fork test, X-ray mastoid, culture sensitivity, these things, and treatment: surgical, canal wall down and canal off procedure. Okay, the surgical we have main thing is to primary is to remove the disease and the ear shape. Secondary is to preserve the or reconstruct the hearing, but never at cost of primary aim. Two types of surgical procedure are done to deal with cholestoma: canal wall down, canal off wall off procedure. Okay, and this consists of atherectomy, modified radical mastectomy, and radical mastectomy. Okay, so we can remember by MAR. MAR means MAR. Okay, so or we can remember by RAM. RAM means radical mastectomy, atherectomy, and modified radical mastectomy. Okay, and in canal off procedure we have these things. Okay, so in canal off procedure, here this is removed by the combined approach through the meatus and mastoid, but retaining the posterior bony metal wall intact. Okay, thereby opening open mastoid cavity. Okay, it gives dry ear and promises easy reconstruction of ear mechanism. However, there is danger of leaving some cholestoma behind. Okay, so some surgeons even advise routine re-exploration in all cases after 6 months or so. Canal wall off procedure are advised only in selected cases. In combined approach or intact canal wall mastectomy, this is removed both formatally and through cortical mastectomy and posterior tympanometry approach, in which a window is created between the mastoid and the middle ear to facial recess to reach sinus tympani. Okay, so now reconstructive surgery. Okay, myringioplasty or tympanoplasty, conservative treatment. Okay, so management of cholestoma but can be treated in selective cases. Okay, so this thing, and tubercular otitis media. Okay, and this is the last topic for today, and this is in most cases infection is secondary to permanent tuberculosis. Pathology: slow and insidious. Tuberculosis appear in the submucosal layer of middle ear, cleft, and caveat. There is painless necrosis of tympanic membrane. Multiple perforation may form which coalescent to form single large perforation. Okay, and the clinical feature consists of painless ear discharge, perforation, hearing loss, facial paralysis. Diagnosis: X-ray, chest, other evidence of tuberculosis. DNA probe, PCR. Treatment: systemic and tubercular therapy. Local treatment in the form of oral toilet and control of secondary pyogenic infection. Master surgery indicated for complication. Healing is delayed in tuberculosis cases. Wound breakdown and fistula formation are common. Reconstructive surgery of middle ear till anti-tubercular therapy has been completed. Okay, so now let us know everything. Okay, so we have discussed about parts of middle ear, parts of ear that is situated to bone. They are squamous, petromastoid. Okay, and more petromastoid, tympanic, okay, and squamous and zygomatic. Okay, and these are the parts that are related to bone. And next thing we have talked about, you can see in the figure as well. Okay, now same thing: zygomatic, tympanic, structural process, petromastoid, and squamous. And we have talked about the middle ear. We have talked about the middle ear diseases. Okay, and before that we have discussed about anatomy of the external ear, middle ear, and inner ear. Okay, and we have talked about development. External ear that is derived from first and second pharyngeal arches. Pinna is derived from sixth ear, and from middle ear that is derived from first and second pharyngeal arches. Malleus and incus that is derived from first arches, and stapes that is derived from second arches. Middle ear cavity and institution from first arches, and tympanic membrane that is derived from all three ears. Okay, and lastly we have talked about otic vesicle, otic capsules. Okay, otic capsule gives bony labyrinth, and otic vesicle that gives membranous labyrinth. And you can see over here middle ear cavity. Middle ear cavity is middle ear cavity consists of lateral border. Lateral border consists of tympanic membrane. Tympanic membrane, on the basis tympanic membrane, lateral border can be divided in three parts. They are epitympanum, mesotympanum, hypotympanum, and this is the lateral cavity. This is the cavity, okay, middle ear cavity. Okay, you can see our anterior, medial, floor, lateral. Okay, over here, and this is the structure. Then we have talked about the ear vesicles, eustachian tube. Eustachian tube main function is, and we have discussed about main function is what? Main function is to maintain the atmospheric air pressure and do discharge, helps in secretion. Okay, if there is secretion blocks, because the eustachian tube consists of the narrowest part that is called as that is isthmus. If that isthmus get blocked, then what happens? The secretion that is not drained out, that is collected in the middle cavity, and what happens? After a few days, after few weeks, what happens? The fluid get infected with the infected. Okay, and what happens? Then infection tries suddenly, infection rise, and what happens? There will be formation of discharge, and discharge will causes pain over there, and in this there will be no discharge, there will be collection of the pus. This pus will causes pain in the ear, and that will be more severe in the night time, and there will be perforation take place. Okay, and different things, and we talk about the venous drainage, blood supply, nerve supply. Okay, and then we talk about a disease, acute otitis media, and then how we treat the cases and how we diagnose the cases, and then we move furthermore with the tympanic membrane. Tympanic membrane composed of two parts. They are pars tensa, the pars flacida. Okay, and pars tensa composed of central and peripheral part, and if the perforation takes place in peripheral, that is called as etiological type. The central type is called tubotympanic types, and then we have topic on mucosal and squamous disease. And mucosal diseases, so there is mucosal diseases, we have talked about mucosal diseases that is also called as tubotympanic types, and this is persistent perforation in the pars tensa. Okay, and when there is persistent perforation, then what happens? There will be discharge, and there will be hearing loss. Okay, there will be active and inactive stage. Active stage, we have talked about here, discharge and hearing loss, and what type of discharge will be there, what type of perforation will be there, what type of mucosa will be there, and either vesicle is intact or not, that we have to know about. And then we do examination, certain examination, we confirm, and then we move further. Then we look for perforation. On the basis of perforation diameter, then we approach the treatment approach. Okay, when the perforation is about 2 mm, then we will do chemical corrective, graft, manioplasty. If the perforation is more than 2 mm, then we have to do manioplasty. Manioplasty indication we have done about, it will be more done after 7 years of age. Okay, and what is the aim of manioplasty? To permanently stop ear discharge, to improve hearing. Okay, and then we talk about underlay and overlay. Underlay incision, we talk about incision. Flap, we talk about flap, and we also talk about overlay over here, and we talk about ossiculoplasty over here. Tympanoplasty, one of the most important thing over here is tympanoplasty. Okay, tympanoplasty means to remove the disease from the middle ear. Not we have to remove the disease from middle ear, we have to reconstruct the middle ear hearing mechanism with or without tympanic nerve grafting, without master surgery. Okay, and now next thing, final topic, that is chronic, most important topic, that is called as chronic otitis media, that is also called as eticoenteral type, squamous type. Okay, that is cholestoma, and symptoms over here, and how we manage the case. We have canal up and canal down procedure. Here we do canal wall down procedure. Mainly they are modified radical mastectomy and eticotomy and radical mastectomy. Canal up procedure are not so indicated. If they are indicated, then what happens? We have to do follow up after 6 months as well. Okay, so we have to do re-exploration as well. Okay, so that is the things, and reconstructive surgery, conservative also we can manage. Okay, and this is the things, and lastly, we talk about tubercular otitis media. Okay, and you can see over here pathophysiology, clinical feature over here. The most common chances over here is fistula formation. So fistula formation, and then we can there is paralysis, hearing loss, perforation. Okay, and this perforation will result in a fistula formation. I already mentioned about that thing as well. And there will be painless ear discharge. So if the discharge is painless, then we have to suspect this thing as well. Okay, and this thing, and diagnosis over here. Okay, and treatment. So we cannot do surgery till medical therapy completed. Okay, so this is the things. With these things we have completed about medial ear and its diseases. I try to cover, and this is my presentation over here, and I hope I have completed my all the topic over here. I have enjoyed the video. Thank you.